Hi everyone, I'm Curtis Van Doormaal and welcome to Neuroanesthesia Rounds for this 9 November 2021. It's being presented to you from Western University and today's talk is Neuroanesthesia and Pregnancy. I hope you enjoy. I'd like to frame this question with a case. Imagine yourself looking after a 28-year-old female who's 24 weeks gestational age with a twin pregnancy. She's been admitted with a new diagnosis of frontotemporal mass with mass effect and early symptoms of new unilateral motor weakness. She is pending craniotomy and tumor resection, and you're responsible for planning her case. When should surgery be performed? How would you conduct this anesthetic? To outline my talk, I'll touch on the following topics. It'll be important to first review the many physiologic changes in pregnancy, as these have such a large impact on how neurosurgical procedures will be performed in this population. I'll then review more specifically the management of intracranial disease and craniotomy procedures, as well as neuraxial anesthesia in parturients with intracranial pathology. I'll move on to touch on spinal diseases as well as interventional neuroradiological procedures in pregnancy. And I'll end on a summary slide, which will hopefully be a springboard for conversation. There are many changes in maternal physiology of which we are very familiar. For the neuroanesthesia practitioners in the crowd, some of these may remind you of your residency days. Neurologically, there is report of decreased MAC requirements as well as sensitivity to local anesthetics. This is further characterized by sensitivity to certain medications, including opioids, and the risk of respiratory depression. There's an increased risk of intraop awareness. From the respiratory system, the upper airway is known to be edematous and friable. At least one Mallampati score greater than baseline. A second Mallampati score often if labor is considered. Then there's a decrease in FRC while maintaining a closing capacity similar to the non-pregnant state, while increasing oxygen consumption more than 60% above baseline. These together lead to rapid apneic desaturation. An increased minute ventilation, mostly in tidal volume, leads to respiratory alkalosis at baseline with a PaCO2 of around 32 millimeters of mercury. The pH around 7.42 to 7.44. The cardiac system is where some of the most significant changes occur, with an increase in blood volume of approximately 50% above baseline, and this primarily in the plasma segment more so than the red cell mass. This leads to a dilutional anemia with a hematocrit of low normal between 30 and 35%. The increase in cardiac output at term is significant, and this has increased another 60% in labor and is its most important as a result of autotransfusion in the immediate postpartum phase, up to 80% above baseline. There are significant considerations associated with aortocaval compression in the supine position after 20 weeks gestational age, which warrants recurrent consideration. Then there are the other organ systems that are also affected, including the GI system with lower esophageal tone decrease, delayed gastric emptying, especially in labor, and an overall increased aspiration risk. These patients are considered full stomach, even electively. From the renal and hepatic system, there is an increase in aldosterone and sodium and water retention. There's a significant increase in renal blood flow and glomerular filtration rate of greater than 60%. And this leads to a decrease in the BUN and creatinine by half to two-thirds of their baseline. Even a normal creatinine would be considered elevated in this population. There is decreased plasma cholinesterase, but this is not to significantly impact metabolism of succinylcholine. And there is a slight increase in transaminases and LDH, which can accompany the pregnant state. Regarding the epidural vascular system, there is increase in intra-abdominal pressure and IVC compression, which leads to epidural venous pressure increase and engorgement of the epidural veins. This can be significantly problematic for patients in the prone position as well as for spinal procedures. The arterial system shows degenerative histological changes secondary to progesterone and estrogen influence. These structural changes and hemodynamic changes of increased cardiac output predispose to spontaneous hematoma formation, albeit rare. Uterine blood flow is a regular concept in obstetrical anesthesia, which is analogous to cerebral blood flow in many ways. At term pregnancy, uterine blood flow increases to 700 to 900 mils per minute, or 10 to 15% of cardiac output. And remember, this cardiac output is increased from baseline significantly. The usual uterine blood flow is only 70 mils per minute in the non-pregnant person. At term pregnancy, this means that uterine blood flow rivals cerebral blood flow, which is also thought to be 15% of cardiac output. Whenever anyone is receiving treatment, in particular neuroanesthetic care, it's important to consider and understand the important implications of uteroplacental drug transfer. The placenta membrane is a semi-permeable barrier, mostly involving passive diffusion. Sounds familiar, doesn't it? Maternal drugs often reach fetus. This is mostly based on concentration gradient, low molecular weight, lipid solubility, the degree of ionization which would reduce the transfer, and the overall membrane thickness. There is a concept of ion trapping in fetal acidosis, whereby weak acids are trapped in their ionic form with the relative acidotic state of the fetus compared to maternal blood, not allowing transfer back to the maternal bloodstream. There are many drugs that contribute to teratogenicity and organogenesis challenges in early pregnancy. This is outside the scope of today's talk. Specific mention for drug transfer is warranted. The vast majority of our anesthetics, volatile, IV, cross the placental barrier. Nitrous oxide in early pregnancy is considered controversial, although it's uncommonly used in neurosurgery anyways. Beta blockers, nitroprusside, and nitroglycerin all cross. There is some concern about nitroprusside infusion and cyanide accumulation in fetus. Both neostigmine, but more so than glycopyrrolate, have small transfer. As a result, atropine is preferred as the anticholinergic of choice, paired with neostigmine for neuromuscular reversal. Warfarin crosses, and this is problematic, and therefore is contraindicated in pregnancy. Of note, neuromuscular blockers, heparin, and insulin all do not cross as a result of their size and their charged molecule status. This table algorithm shows consideration for whether a neuroaxial procedure is safe in the presence of intracranial pathology, which is thought to be a relative to absolute contraindication. The concern is for a drop in intracerebral pressure and brainstem herniation with a dural puncture. What's important here is that there's evidence of significant mass effect. And if this is significant, it should be avoided. If there's only minimal or subtle mass effect and no evidence of hydrocephalus, then it may be reasonable to allow neuraxial anesthesia, particularly epidural anesthesia, where dural puncture is not part of the procedure. Inadvertent dural puncture should always be considered as a significant high-risk complication in this scenario and is not for the faint of heart. The risks and benefits should really be weighed carefully, whereas neuraxial anesthesia is the most common and routine anesthetic of choice in the obstetrical population. Let's revisit our first case. Remember, she was pregnant with twins at 24 weeks gestational age and has a new mass with some small symptoms. When should surgery be performed? Well, it's often not possible to wait until delivery, although this would be ideal. The best time for non-obstetrical surgery is in the second trimester, and we should always ask ourselves whether the baby should be delivered prior to undertaking intracranial surgery. In terms of this anesthetic, there are many conflicts. These are uncommon scenarios where both intracranial pathology and pregnancy coexist, and therefore there's low evidence base for any given approach above another. Multidisciplinary planning is often beneficial in a tertiary care center involving all the relevant stakeholders: neurosurgery, anesthesia, neuroanesthesia, specifically obstetrics, and an ICU. There are a number of considerations that any senior resident would be quite all too familiar with, and these are often in conflict with the neuroanesthesia considerations. I want to highlight a few of the important ones. The full stomach and difficult airway may necessitate a different approach to induction of anesthesia compared to a typical graduated neuroanesthetic induction, maintaining cerebral perfusion. Maximizing oxygen delivery to injured brain is paramount, and yet the rapid apneic desaturation that occurs in pregnancy is in conflict. Maximizing placental perfusion is at odds with prone positioning in spine surgery. Maintaining and avoiding fetal toxicity, both to drugs or to radiation, is in conflict to typical workup or investigations required for neuroangio procedures. This balance is all best illustrated in this table here, where the risks to fetus are balanced off by the considerations for the neuroanesthesia requirements. The bottom line is this: the optimal care for mother and minimization of harm for fetus is the overarching neuroanesthetic goal. This leads us to 3 neurosurgical scenarios. You have a benign lesion that's asymptomatic. It's probably best that we wait until delivery and have active surveillance. If there's a malignant lesion with mild to moderate symptoms, or even without symptoms, neurosurgical indications would generally prevail in terms of offering surgery. These should incorporate obstetrical and fetal concerns and consider whether a cesarean section prior to resection is indicated. In the emergent acute bleed or increased ICP patient, it's clear that the acute neurosurgical priority is paramount. The following table demonstrates some of the thought process about how to triage patients with neurosurgical indications. Electively should be delayed. Those that require surgery in the early trimesters of pregnancy, one should consider whether waiting until a second trimester is indicated or safe. If there's greater than even minimal risk to the mother, one should proceed with neurosurgery at the time of diagnosis. This is because of fear of neurological deterioration if waiting is exceeded. And it's clear that emergency neurosurgery cannot wait, for the status of the mom is what determines the status of the fetus. One should administer the best possible neuroanesthesia for mother, and this typically leads to increased fetal well-being. With regards to OB timing and delivery, if it's less than 24 weeks gestational age, fetal management would be according to the obstetrical provider. If it's very early pregnancy and a significant malignant etiology, this may include termination of pregnancy. If viable age at the time of neurosurgery, is delivery appropriate? Neurosurgery could be performed with the goal of maintaining fetus in utero in early pregnancy. Or cesarean delivery before a neurosurgical procedure concurrently could be considered. Or a cesarean delivery followed by later neurosurgery might be indicated. Neoplastic lesions do occur in pregnancy, however, the incidence is not greater. However, some meningiomas may be hormone responsive or simply pre-existing tumors become symptomatic because of possibly increased edema during pregnancy, but were present prior. Gliomas are rare but pose fetal and maternal risk to life and often require adjuvant chemo and radiation, which are further challenges while pregnant. And other types of tumors, including pituitary adenomas, can become symptomatic, or metastatic lesions, for example, from the thyroid, have been described. The idiom of delayed intervention often results in maternal deterioration requiring urgent intervention, tends to justify early intervention and not withholding treatment simply because someone is pregnant. Intracranial hemorrhage is a rare event, but happens at a significant frequency in pregnancy. 7% of pregnancy-related maternal mortality is a result of intracranial hemorrhage. And those with intracranial hemorrhage carry 20% mortality risk in pregnancy. A subarachnoid hemorrhage from a ruptured aneurysm makes up 65% of these, with the bulk of the remainder from bleeding AVMs. There are other rare causes, including hypertensive intracranial hemorrhage and vasculitis in rare cases. Although it's not thought that AVMs bleed any more commonly in pregnancy, the risk of rebleeding of a symptomatic AVM is at least 25% within the same pregnancy, and therefore a craniotomy with evacuation of hematoma and resection of AVM is the best means to avoid rebleeding, which can be catastrophic. The risk from intracranial hemorrhage as a result of aneurysmal bleed is quite high, leading to high morbidity and mortality, and this is exacerbated by the increased blood volume and cardiac output, as well as hormone-mediated vascular changes. The trauma in the obstetrical patient is similar to the non-obstetric patient. However, careful consideration of intimate partner violence as an increased risk during pregnancy and should be considered. There are modified ATLS priorities, including maternal resuscitation, early blood products, and left lateral tilt position. The traumatic brain injury guidelines for the non-pregnant patient tend to apply and are extrapolated to the pregnant population, including CPP, maintenance, avoiding hyperglycemia, maintaining normothermia, treatment with isotonic or hypertonic fluids, non-glucose containing fluids, as well as ongoing ICP management and detection where warranted. So what do we do if we have one of these patients prior to surgery? Are they on anticonvulsant therapy? Some of the altered pharmacology of pregnancy, including increased clearance and decreased protein binding, as well as teratogenicity, need to be considered. Of course, uncontrolled seizure can be significantly problematic for both mom and fetus. Therefore, appropriate anticonvulsant therapy may be indicated. For the parturient, aspiration prophylaxis is usually indicated in the form of an H2 antagonist, for example, famotidine 20 milligrams IV, a non-particulate antacid, such as 30 milliliters of sodium citrate orally, and a dopamine antagonist, metoclopramide 10 milligrams IV for gut transit, and these within 30 minutes prior to surgery to reduce the risk. As I mentioned earlier, the induction can be challenged between the aspiration risk of a pregnant patient as well as their difficult and friable airway, the need for a small endotracheal tube, as well as the controlled neuroinduction for someone with raised ICP. This box shows one possible method or approach to induction for craniotomy in a pregnant patient, according to Cottrell and Patel's chapter. We talked about aspiration prophylaxis on the previous slide. Left uterine displacement should be performed in all pregnant cases over 20 weeks. Dedicated and deliberate preoxygenation is required. And typical to slightly lower doses of induction agents are indicated. High-dose rocuronium is preferred. Most often, although succinylcholine can be considered in the right cases, although it does briefly raise ICP. There may be a need for mass ventilation with cricoid pressure, which is a form of hedging on risk. And of course, 100% apneic O2 is recommended. Bag mask ventilation can be avoided altogether. However, in the acutely raised ICP, avoiding hypercarbia is paramount. For the intraoperative management of the pregnant patient, a number of hemodynamic monitoring equipment is indicated in the form of arterial line, maintenance of cerebral perfusion as well as uteroplacental perfusion, consideration of appropriate fluid administration to maintain euvolemia or relative hypervolemia. Should avoid aortic caval compression. There should be early and prophylactic vasopressor use to target hemodynamic goals. The positioning should incorporate left lateral displacement of the uterus, for example, in lateral position. Large bore IV access or central venous access is warranted. Concerns over bleeding, VAE, the need for vasoactive infusions will help make this delineation. Phenylephrine is the vasopressor of choice in pregnancy in lieu of ephedrine, or in lieu of epinephrine and norepinephrine, which are known to decrease placental perfusion with vasoconstriction. BP targets are narrow in the pregnant population to preserve perfusion near baseline, no lower than 20% and no higher than 20% from baseline. And this may be in conflict with some of the targets in intracranial pathology. For example, if one were seeking controlled hypotension in vascular procedures, this may be poorly tolerated by fetus. Intraoperatively, the pregnant patient during neurosurgery will often require increased ventilation because of pregnancy indication, but also controlled hyperventilation in the setting of raised ICP, though this should, again, not exceed 25, as this would lead to uterine artery vasoconstriction, a left shift on the PaO2 curve, and frankly is shown to have worse outcomes in the non-pregnant population anyways. Therefore, the target should be between 25 to 30 millimeters of mercury in the raised ICP patient. The depth of anesthesia should be adequate to reduce awareness and avoid hemodynamic effects of excess depth. A PSI or EEG monitor is often indicated if there's room to position these. Intraoperative seizure is also possible, and these can be useful tools to detect these. Temperature regulation should be strictly controlled and maintain a normothermia typically. There aren't very many indications for hypothermia, and there's certainly harm with hyperthermia. With regards to IV fluid therapy, the osmotic agents are worth conversation. Mannitol, for example, has been shown to slowly accumulate in the fetus, leading to hyperosmolality. In animal studies, the mannitol tends to cause an osmotic gradient, which can lead to fetal dehydration, which is a significant concern and has led some to recommend that mannitol is contraindicated in the pregnant patient. However, many texts, including Gittrell and Patel, suggest that usual or small doses of 0.25 to 0.5 grams per kilo appear safe and well tolerated. Furosemide can be used cautiously, but hypovolemia should be avoided. Typically, urine output monitoring would be required anytime these are being utilized. Otherwise, isonatremic, isotonic, glucose-free solutions still apply as in typical neurosurgical procedures to reduce cerebral edema and hyperglycemia. An alternative of hypertonic saline can also be used with similar concerns as mannitol. Steroid treatment is common with intracranial tumors, and dexamethasone is the agent of choice because of its low mineralocorticoid effect. From the parturient perspective, this actually has a positive effect of increasing lung maturation and increasing surfactant in the preterm infant. Usually betamethasone is utilized in this population, but dexamethasone can be a useful surrogate. As far as antiemetic prophylaxis goes, most are safe in pregnancy since they are commonly used with hyperemesis gravidum in early pregnancy, and they have not been shown to be any significant teratogenicity. For maintenance of anesthesia, most usual approaches for craniotomies are reasonable. This box is one example of an approach that can be used with fentanyl, isoflurane, a non-depolarizing muscle relaxant, or a TIVA with propofol if there's concerns of a need for increased brain relaxation. There are, of course, many other acceptable options, including remifentanil, which, because of plasmasterases, has very low neonatal respiratory depression risk and may be ideal. Sevoflurane and other fluorinated volatile anesthetics are reasonable, and they all, of note, lead to uterine relaxation, which can be concerning in the advent of postpartum hemorrhage if this is being combined with a neurosurgical procedure after cesarean section. Postoperative management of the pregnant neurosurgical patient often requires monitored unit at the very least, and often an ICU, and this should be anticipated. The NICU is also required for the fetus if it's any concerns of preterm or the use of a general anesthetic. Regarding extubation, this will be indicated based on typical indications for extubation, the hemodynamic stability of the patient, the need for ongoing respiratory support, or a decreased neurological status requiring recovery, and the concern about accumulated airway edema or the absence of leak after prolonged prone procedures. DVT prophylaxis is indicated in pregnant patients as they are hypocoagulable. However, there is significant concern of pharmacologic agents such as heparin and low molecular weight heparin regarding the risk-benefit in the acute neurosurgical patient, as there is an increased risk of intracranial hemorrhage post-op, and this must be balanced with the increased risk of venous thromboembolism in pregnancy or in the immediate postpartum phase. Non-pharmacologic use of TED stockings, SCDs, and encouragement of mobility are low-harm interventions that may be beneficial. Pain control continues to be important post-op. Generally, there is less pain than extracranial surgery, but there is still moderate severe pain described in at least 50% of the people operated on. Pain control will reduce morbidity and enhance maternal comfort and mobility. The typical approach of multimodal analgesia with acetaminophen and opioids, which are safe in pregnancy, as well as local infiltration and scalp blocks, can be considered. Morphine and hydromorphone are prototypical opioids safe in pregnancy and in the breastfeeding patient, although there is some breast milk contained within the breast milk at low doses, which needs to be considered. Tramadol and Tylenol 3 should be avoided, as their pharmacodynamics and pharmacokinetics are less predictable. And tramadol especially lowers the seizure threshold, which may not be ideal in a neurosurgical population. Special care for NSAIDs in select cases only. These should be avoided in the parturient itself, as well as consider platelet inhibitory effects in the coagulopathic patient at risk of intracranial hemorrhage. Cerebral vasospasm can occur after subarachnoid hemorrhage in the pregnant patient as well. In some ways, pregnancy confers hypervolemic and hemodilated state at baseline, and probably inducing hypertension, such as in preeclampsia, may be unwise for many reasons. Oral nimodipine has never been tested in this population, and it's potentially teratogenic in animals. Magnesium sulfate, however, has been shown to reduce vasospasm and is the treatment of choice in eclampsia, and so may be the agent of choice in this population as well. Other options, including neuroangio, intraarterial verapamil, or piperavine, have low experience in the pregnant patient. There is concern of cumulative radiation. The second case involves a 33-year-old female at 35 weeks gestational age with chronic back pain. She presents with a 3-day history of severe back pain radiating to the right lower extremity. There's also significant urinary incontinence, constipation, and perineal anesthesia for 1 day. What's your differential diagnosis? If you thought about this for a while, the list gets pretty long. But the top ones for lower extremity weakness in pregnancy include magnesium toxicity, since this is a common infusion in the pregnant patient, spontaneous spinal hematoma and cauda equina, which is very possible, and a cannot miss pathology, as well as acute disc herniation and radiculopathy, which may be the case in this particular case. The remainder of these will have many reasons for this acute presentation being less likely in this particular individual. An MRI scan of this patient's lumbar spine shows an acute disc herniation with significant spinal cord compression, as evidenced in this MRI scan. So why would you conduct spinal surgery in pregnancy? Well, the spinal tumors cause mass effect. There could be bleeding from the tumors. There may be a spontaneous hematoma on its own. There could be vertebral vascular malformations or lumbar disc displacement in cauda equina. There are case reports of epidural analgesia and self-prone patients in lumbar laminectomy procedures, which is an interesting approach and is possible. The prone position does lead to difficult monitoring, difficult to access the patient in the setting of emergent cesarean section need, and there is increased epidural venous bleeding in both pregnant patients and in the prone position, which can exacerbate things. Placental perfusion may increase, actually, as long as the gravid abdomen is not compressed, such as in a Wilson frame or a Jackson frame with the abdomen free of compression. A staged spinal procedure after cesarean section is a viable option. Neuroangio procedures in pregnancy are fraught with some controversy. There may be a need for coiling of vascular lesions or aneurysms, and they form a minimally invasive alternative to surgical approaches, and this is appealing. The out-of-OR environment leads to some unfamiliarity of assistance from the anesthesia perspective, and this can take a complex patient with difficult physiology as well as a procedure with potential devastating complications, making management challenging. There is always maternal concern as well as appropriate healthcare concern of radiation exposure. You need to consider the fetal age, the dose, and the indication for procedure. The ALARA principle applies, as low as reasonably achievable, and balancing risk and benefit is always paramount. And whenever that's involved, I think the decision-making becomes more clear. There is decreased access to the airway with the C-arm in the way. There's more difficult to position the patient properly, for example, in left lateral tilt. There may be a need for general anesthetic versus conscious sedation, which can be challenging in this environment. And then what occurs when there's a acute intracerebral catastrophe, such as a vascular rupture? There may be a need for emergent anticoagulant antiplatelet reversal, as well as conversion from sedation to general anesthetic, and emergent vascular procedure to stabilize this pathology. For example, in this population, consideration of an arterial line, a GA with an endotracheal tube, TIVA for maintenance, fetal heart rate monitor when blood pressure control is used to ensure uteroplacental perfusion. Regarding neuroradiological procedures and radiation exposure, clearly early pregnancy is the most problematic, and this risk decreases with fetal age. The dose also matters, of course. The max Roentgen equivalent MAN, or REM, which is equivalent to 10 millisieverts, is 0.5 REM. The fetal dose of 0.3 occurs with coiling of intracranial aneurysm, and cerebral angiography is 0.1 when an abdominal shield front and back is used on mum. For comparison's sake, a single CT scan of the head is 0.01 REM. A note on fetal heart rate monitoring, as this comes up often. According to the American College of Obstetrics and Gynecology, this should be individualized use in consultation with OB and requires 5 key considerations. Number 1, the fetus must be viable. Number 2, it should be physically possible to perform the monitoring. Number 3, there should be a healthcare provider that can perform a cesarean section present while you're monitoring. Why else would you monitor? Number 4, maternal consent to perform emergency C-sections in the event that it's indicated. Number 5, that the nature of surgery will allow interruption to provide access to perform emergency surgery. For example, an open spine and prone position makes this very difficult and unlikely to be possible. Severe fetal bradycardia mandates improvement in uteroplacental flow and fetal oxygenation. And so in that sense, having low and sustained bradycardia may be good signal to alter your anesthetic approach. And though we can detect fetal heart rate monitoring anytime after 16 weeks gestational age, changes in baseline such as bradycardia and tachycardia are only predictive of neonatal mortality after 24 weeks. Of course, these changes can occur in healthy fetuses as well, and drug-induced loss of variability are common under anesthesia, making interpretation difficult. So let's briefly summarize. The neurosurgery in pregnant patients is rare, with limited evidence-based approaches. Neuroanesthesia and intrapartum consideration pose many conflicts with one another. Maternal resuscitation does drive fetal well-being most of the time, with some careful caveats. Neurosurgical indication typically drives timing of surgery, unless the risk is low, and then obstetrical considerations play more of a role. A multidisciplinary approach is beneficial in these complex cases. Consider a staged cesarean section followed by neurosurgery in late-term cases, eliminating the concerns of fetus in that approach. Alternate intraop position, lateral or Wilson or Jackson frame for prone may confer a suitable compromise to avoid aortocaval compression while providing neurosurgical exposure and the opportunity to monitor fetal heart rate. The ALARA principle applies for neuroangio, considering a risk-benefit ratio always. I hope you enjoyed my talk, and I'd like to open the floor for discussion at this time. These are the references that were utilized to conduct this talk.